Hello, I'm Dr. Richard Krasuski from Duke University Medical Center. I'm joined today by my esteemed colleagues, Dr. Rajan Sagar from UCLA and Dr. Paul Forfia from Temple University Medical Center. Today we're going to continue our discussion about the advanced patient with pulmonary arterial hypertension, management of that patient, particularly in the ICU setting. So Rajan, you have a patient who ends up in the intensive care unit. They are failing, basically. What kind of precipitants for that failure should you be looking for, and what kind of things can we treat to potentially get that patient out of the ICU quickly?
So Rich, that's a really actually important question. We sort of grapple with this for any patient that comes to the ICU with a failing right heart. And one of the key issues is the trigger. It's almost akin to a DKA patient, where you're actually trying to find out exactly what caused the DKA. In many of these patients, I think the majority of them, I would argue, have a trigger. And when you do a full search for that trigger, if you don't find one, only then can you say that this is probably progression of the underlying disease. But one has to really exhaust, I think, the search. I think the usual triggers are infection. It can be something simple like an obvious pneumonia or infiltrate on a chest x-ray. It can be a low-grade sepsis, urosepsis comes to mind, a hot gallbladder. There's many different, I think, triggers. I've even seen simple GI bleeds, a simple anemic insult, if you will, sort of, creating the scenario of a failing right heart, or at least contributing to that presentation. So I had a case recently where we went through this whole algorithm, but at the end of the day, it was determined that this was progression of the underlying disease. And when I did a thorough search of what had happened in the last 6 months, this individual had also developed an atrial arrhythmia 3 months earlier that had to be ablated at an outside institution. And you could see how there was a progression towards this what we were calling acute right heart failure, but really there was a subacute component. So getting a really accurate history of what was going on at home or over the last 3 to 6 months, I think, is sometimes really helpful as well.
Those are all excellent points. One of the other things that I've found is getting a family member, getting history from the family member, because sometimes patients will do things like just be non-compliant with their medications, and I found that's a really frustrating thing when you miss the fact that they're not taking their medicines acutely.
That's an important one.
And they quickly deteriorate. So Paul, going in this direction, so now you've identified some of these potential triggers, but the patient's still not better, and you're trying to figure out, what am I going to do next? What am I going to start? How am I going to approach this particular patient? And how am I going to determine what level of acuity to take towards them?
Yeah, so obviously it's highly specific to the individual scenario, and and for that matter, it's not just the trigger that tipped the patient over, but also the degree of cardiopulmonary reserve that the patient had before the trigger came on. So if you have a patient who has moderate severity phenotype of pulmonary arterial hypertension, and they have rapid atrial dysrhythmia, and the patient comes in and decompensated heart failure, you treat the underlying PAH and heart failure, you restore sinus rhythm in the appropriate manner, and oftentimes you'll have a large improvement back to their prior functional baseline, because they had enough reserve to rebound from that acute insult. You turn it around and it's a patient who has relatively advanced stage PAH, and then they come in, like Dr. Sagar noted, with a pneumonia or an atrial arrhythmia. And it is unfortunately common that those patients never recover, because once you have gotten to them to the point where they have ICU level needs, you correct the underlying trigger, but then you're calling on the patient's organ reserve, nutritional reserve, skeletal muscle conditioning reserve in order to rebound from that complex hospitalization, and the patient simply can't do it. So much of it, as you guys alluded to just before, has to do with what the patient was bringing to the table prior to their decompensation. So if I see that a patient was already at a baseline level of severe disease or relatively advanced disease, and then they are triggered into a state of decompensation, I'm already going to recognize that once that trigger is resolved, we may have to face the fact that the patient is going to be in a state that is relatively end stage. And I'm going to be thinking about things like a relatively urgent transplant listing discussion, because we may not get that patient back to where they were before.
So brilliant discussion, gentlemen. On one hand, we have the triggers, things that potentially are outside the field of pulmonary hypertension that could make the pulmonary hypertension worse, make the patient sicker. And on the other hand, we have the disease process itself. And really, it's a matter of coalescing those two and thinking about both when you approach that patient. I thank everybody's attention.